I want to focus on, actually the only two you're going to be able to fix or do something about, are opiates and TCAs. More people have died in the last 10 years from opiates than in the first 10 years of the AIDS epidemic. Think about that. This is something that is addictive, readily available, all-consuming, and kills you. Worse than HIV. Give them Narcan if you suspect it. Check their pupils if they're pinpoint. You can fix it by fixing the hypoxia. TCAs, what's the treatment?
Sodium bicarbonate.
Yeah, this is a great time for sodium bicarbonate. Rutland?
Sorry to interrupt you. But once a person is in arrest, the first goal of treatment is really to reverse the hypoxia. Not to get naloxone in cardiac arrest, undifferentiated or suspected opiates is not, to my knowledge, not life-saving. It's really the reversal of hypoxia. So when you're doing, even if it's a suspected overdose, really your goal of treatment is to fix the hypoxia before you reverse the naloxone. It's not causing direct cardiac injury, it's causing hypoxia, which is leading to arrest.
Yeah, absolutely. So you intubate them, you oxygenate them. Just also prioritize your oxygen. I couldn't find any data that it helps. Doesn't hurt though, for sure. And sodium bicarb, what do you think the dose is for sodium bicarb? We usually give an amp. So traditionally until the QRS narrows, I straw polled our class. The most sodium bicarb given in our class is about 28 amps for one patient, TCA overdose. Probably fixing the sodium channel blockade, not the acidosis. Just keep in mind, you give it until, if you have a story that just took that and they rest in front of you, your goal is to do normal ACLS, but tons and tons of bicarb from pharmacy, empty it. All right, real ultrasound. I had a patient. What is this? Yeah. So a tamponade arrest is a PEA arrest, and that's because, again, the electrical activity is okay, but you can't perfuse your heart. It's actually more likely lack of preload than lack of afterload, because the RV can't fill. And this is on my life to-do list. I've never gotten to do it, but quick picture. I find the sub-xiphoid the easiest view to get. I would, if I had to do it, or when I get to do it, I would do an ultrasound-guided one. How much fluid causes tamponade? What's the minimum amount? Yeah, and how much is the lowest that I could find, or that is easily findable that caused a death? The tamponade physiology, 50, a death, 100. FYI, this patient had 500. So you can have some sort of weird thing. What patient that we talked about is more likely to have tamponade and effusion? Dialysis patients. So in addition to these people having hyperkalemia, they get uremic pericarditis. You just need a BUN of 60, which I wouldn't even blink at if I saw a dialysis patient with that. So they need a probe thrown on their heart before you call it. All right, tension pneumo, this is case reportable. 2 reviews of a couple hundred people found no evidence that this ever caused an arrest. This is another preload dependent one that just blocks the SVC, and we know how to treat it. Some darts, the chest tube, be better. And then traumatic arrest. If someone arrests in front of you, after getting shot in the chest, what do? CP, and then I think that by Patty is a thoracotomy. How many people have done or seen one? A lot of the back, a couple of the front. What are we looking for in a thoracotomy? Obvious blood. Tamponade is one of the things we can fix. Either side of the chest, so tension pneumo from either side we can fix. Massive hemothorax. And we cross-clamp the aorta, which is what the middle one is a picture of. Who survives these? Blunt or penetrating? Penetrating. Blunt trauma, they're both abysmal, by the way, for survivaloids. Blunt trauma is something on the order of 1 in every 300. Penetrating trauma is reported as high as 18% if they arrest in front of you. This really can work as much as 1 in 5 generally young people. and always open the pericardium. What's a good, prognostic factors? PEA rather than asystole, young age, and signs of life. So moving pupils, and if they rested in the department, all more likely to live, all definitely do it on. How about CPR and traumatic arrest? Anyone know what the data says?
Use
Sorry?
Don't do it.
I heard one of each. So most says it doesn't help. 2016 May one shows in kids it definitely does help. The thought is that the concern is that you're pumping blood into a hole and forcing it further. It's trauma, so don't do it. However, you still get to perfuse your heart if you do compressions, and that's why it works in kids. It's mixed. I think either's appropriate, but I'm doing it in my patients just based on what I could find online. No slam dunk papers. And for those of you who haven't seen one, this is a picture of the scene and how chaotic it can be. I've seen three. There's been the person doing it has stuck themselves in two of them.
Yeah, do a shoulder blade. The shoulder blade. I'll try again. I'll go keep track.
Get the scissors.
Let's open the. He needs a bigger knife. Go in between the ribs with the knife. Get the 4 guys right. Let's go. How much? On the bottom left. Where is it? Over there, ribs right there. Grab those. Pull that tube up. Here, Frankie, pull the tube back, yeah. Right. I know, but he doesn't have space here. That's the wrong way. Go ahead. Swing on the right chest. Go ahead. Slam.
Take the left hand to top the structure.
You got the big clamp?
Right there. Take
it on a cross. You're going to have to go right on the cross up there. Open that chest up more. Open up the chest more up there. Take your scissors on up here.
All over the sternum.
It's a big climb for the aorta. We need blood. Yeah.
And a phone in 2 minutes. Get a phone with a syringe.
Should be like you're gonna need you may need to cross clamp the aorta. Open it all the way up. All the way up. Cramp or no wide.
Right now I'm on the bed right there.
So that's new, but look at your heart. Hold it, expose your heart.
Right on the chest.
Deliver the heart. Deliver the heart. Let's see. It's got blood yet?
Deliver the heart means open the pericardium.
He's got fluid, whatever we got. He's definitely got cardiac activity. But yeah, that mammary artery bleeding. Clamp that off. But
Not aorta.
are you sure you got aorta?
I feel a pulse. You've got a pulse right now.
He's got a good cardiac.
OG2 down to field A.
Yeah, just make sure. Yeah, put an OG down.
I keep grabbing my hands there.
Who's Larry Miller?
Yeah, the guy in the making.
So this guy got his pulse back, and that was something they were. I don't know if you could tell. The guy recording was actually handing the clamps. That's about as good as one will ever go. So you open the pericardium and deliver the heart, and cross clamp the aorta. They got 200 cc's of blood out of the right chest, and a little longer ago they got some blood out of the heart. But those are the kind of steps you're doing. And then cross clamping the aorta, which means covering it below the area where perfusing perfuses your brain, so you don't lose any blood below that. He went right to the R.
Where was that done?
Around sex.
Question though.
Yeah.
So a lot of people they won't do compression when you're doing it.
Yeah, why would they do that?
Because I feel like if you didn't do, so like in Miami, they talked about often didn't do compression when they're doing this. I think it would be a lot easier, right? Because like I think half of the difficulty is the patient bouncing up and down. This person's trying to make this decision.
Yeah,
I've seen it argued both ways to do compression.
and that's what I found in the best literature search I could do. There's no very, very small studies. In kids, objectively, it does seem to help. Compressions with a traumatic arrest. I would pause for the thoracotomy. But anyone, while we're setting up, which can take a minute, and that's important to perfuse your brain for it, I would do compressions until this step. I have no evidence for that, except that I know compressions help kids walk out of the hospital, and I know it's mixed in adults. That's the best I'm armed with. I know a lot of people don't, kind of a snarky, do less way. I think it's fine, but I would do it.
I think the most important slide was the one you had for the indications, because when you're running trauma month, I'm not sure what it's like in Jersey, but in Miami, they'll do the thoracotomies for things which are completely not indicated, whether they're doing it for education or whatever they believe. That's just what they do down there. But then when you come back and you're running a trauma third year, you follow the literature and you don't do thoracotomies for bone trauma and all this other stuff that they would do in Miami. This is important to know that just because you were in Miami or Jersey for a month and saw tons of stuff, that doesn't have to be the case.
Vinny, how many thoracotomies have you seen?
They do it for everything. They do it for people that had one trauma and then they do it for 30 minutes before they got.
That's a great point. Nice.
And we stick,
And we stick to the indications because this is a low yield, high risk
All the way
procedure.
down to the shoulder blade. The shoulder blade.
Pat made a comment that people get stuck all the time doing this procedure. There's ribs, there's sharps. People are doing chest compressions. It's just a very high risk procedure to do.
All right, I can send this to anyone who wants. I just gotta move through a little bit more. Okay. All right, so in the works. That's where we've come between the first documented sort of bellows thing in the early 1700s to 200 something years from then. We had different types of compressions and breathing. In the last 50 years, in the last 70 years, we've gotten defibrillation and hypothermia and any number of other amazing treatments. In the next 50 years, we're going to be even better. So just what are you going to read about? Best thing we're not using. Anyone kind of read my mind? We had a journal club about it last year. Someone say EPI? ECMO. The read my mind thing is VSE. So study out of Greece a couple years ago, validated in 2013. I see Gabriel is upset. If he disagrees, we'll talk.
No, I pulled the study up during the rest yesterday.
Yeah, this is, so, VSE, vasopressin steroids epi. For epi, people are really down on it. They think not only is there no increased survival, but it might be harmful. I think those studies are small and are not powered to show the survival that they entail. Regardless, vasopressin, 20, 1 milligram of epi, and 40 of solumedrol. Number needed to treat to walk out of the hospital is about 16 to 18. But that was weird, it was a small study. They did a larger validation study in 2013. Even better, I think that was the 14.91. Even better if they have shock. So it's a VSE protocol after the initial treatment in the ER, or this was by EMS. They kept giving steroids. And it's fantastic. And I'm going to use it as soon as I'm attending, because it's a phenomenal, phenomenal treatment. And I bet it's going to become, it'll be talked about and maybe standard of care.
Why the steroids? What's the theory?
What a great question. So, it's not this one. So, in heart attacks and in cardiac arrest, there's inflammation associated with this injury. Increased interleukins of kinds that aren't important, but they're giving anti-inflammatories